Hi, this is Piyush Bhargava and you're watching the Parathyroid scan teaching file. Let's start by reviewing the common parathyroid scan protocol. So the reason we do parathyroid scans is to localize parathyroid adenomas, the most common cause of primary hyperparathyroidism, to evaluate patients who are suspected of having parathyroid hyperplasia and rarely the patients who have a diagnosis of parathyroid carcinoma. The radiopharmaceutical uses 20 millicuries of technetium-99 emcitabine, which is injected IV, and 10 minutes after injection and 2 hours after injection, we acquire planar images of the neck and planar images of the chest. We review those images and decide whether we need spot views or a SPECT CT. Technetium-99M has a photo peak of 140 keV and a physical half-life of 6 hours. The mechanism of uptake of this radiopharmaceutical is blood flow to the adenoma and mitochondrial uptake of the pharmaceutical. There is physiologic activity seen in the thyroid gland. There is focal increased uptake seen in the parathyroid adenomas, and since sestamib is a myocardial perfusion tracer as well, we see myocardial uptake, especially in the images of the chest. The critical organ for this radiopharmaceutical is the colon. Now let's look at a negative study or a negative parathyroid scan. Here in case number 1, we have anterior image of the neck, the early image, anterior early image of the chest, and then at the bottom we have delayed images of the neck and the chest. On the early images, we see that there is diffuse increased uptake in the right and the left lobes of thyroid. We see the same in the images of the chest with some myocardial activity. There is nothing in between. And on the delayed images, we see that the uptake in the thyroid washes out, and we see the same finding on the delayed image of the chest. So this is how a negative parathyroid adenoma, negative parathyroid scan would look like, where you would call this as no evidence of a parathyroid adenoma. Let's look at an abnormal scan now, case number 2. So on the early images, here we see focal intense uptake at the inferior pole of the right lobe of thyroid, which is seen here on the image of the chest. And on the delayed images, we see that the thyroid activity washes out, but the parathyroid adenoma remains. So this is telling the surgeon that they should do a limited dissection at the inferior pole of the right lobe of thyroid and resect a parathyroid adenoma. So that's the utility of doing the parathyroid scintigraphy and identifying the location of a parathyroid adenoma. Otherwise, the surgeons used to do bilateral neck explorations trying to find the parathyroid adenoma. Case number 3, here the abnormal finding is at the superior pole of the left lobe of the thyroid, seen here on the early image, and seen here on the delayed image when the activity in the thyroid washes out, but the parathyroid adenoma remains. Another abnormal study, case number 4. This case shows images from a abnormal parathyroid scan with a parathyroid adenoma at the inferior pole of the left lobe of thyroid, seen here on the early image and seen here on the delayed image. Next case, case number 5. Here on the early images of the neck, there is diffuse increased uptake in the thyroid, which is normal. But on the image of the chest, there is a faint suggestion of a focal uptake in the chest. On the delayed images of the chest, the activity in the thyroid washes out, but the activity in this ectopic parathyroid adenoma persists. So this is a common location, or mediastinum is a common location for ectopic parathyroid adenomas, and that's the finding in this case, an ectopic parathyroid adenoma localized on a sestamib scan. We also do SPECT CTs to localize adenomas. It helps the surgeon to determine their surgery or the surgical exploration. Case number 5 is showing an ectopic parathyroid adenoma in the mediastinum, seen here on the early image and seen faintly on the delayed image, and it localizes to the prevascular soft tissues. Here's the aortic arch on the fused PET CT image, and right anterior to the aortic arch in the anterior mediastinum, we see uptake of sestamib consistent with the ectopic parathyroid adenoma. Case number 7, here we have a 32-year-old female who presented with right flank pain. She was diagnosed with renal stones. She underwent extracorporeal shockwave lithotripsy. These were calcium stones. She had hypercalcemia. Her PTH level was very high at 177.4. On the early image of the neck, we see focal increased uptake at the inferior pole of left lobe of thyroid which persists on the delayed images and is consistent with the parathyroid adenoma. She had a CT earlier which shows this abnormal soft tissue density in the left paratracheal region. Also had an ultrasound of this region of the lower neck, which shows this abnormal echogenicity, a hypoechoic focus in the neck, supraclavicular region with internal blood flow consistent with the parathyroid adenoma. Another parathyroid adenoma localized on a SPECT CT in the region of the right paratracheal groove. Case number 10. Here we did a SPECT and the SPECT CT. Here is the early image showing a focal uptake which persists on the delayed images. And here's a SPECT image, the rotating image. Let me play it one more time. Showing the location of the abnormal parathyroid tissue, which is localized here. This is uptake in the left lobe of thyroid, this is uptake in the right lobe of thyroid, and behind the right lobe of thyroid is abnormal tissue which takes up the tracer and is consistent with the parathyroid adenoma. Another interesting case, early image showing asymmetric increased uptake at the inferior pole of the left lobe of thyroid, which sort of persists on the delayed images, raising the suspicion of a parathyroid adenoma. But when we followed up this patient with an I-123 scan, the uptake of I-123 is concordant with the parathyroid scan, and the focus where we thought there would be a parathyroid adenoma, which is not expected to take up I-123, there is some iodine uptake, suggesting that this focus here, seen on the parathyroid scan on the early image, delayed image, is actually a thyroid adenoma because it takes up I-123. Here is another image with the markers. Our last case for this teaching file, case number 12. Here on the early and delayed images, we see multiple foci of increased uptake in relation to the left lobe of thyroid and the right lobe of thyroid, which persist on the delayed images. And this finding is characteristic of parathyroid hyperplasia. Typically in parathyroid hyperplasia, multiple glands are involved, and that's what we see here. All right, so those are some of the patterns that you can encounter when you're looking at normal and abnormal parathyroid studies. Thanks for watching.